Good morning. Welcome to Deuk Spine Institute. We are streaming live spine surgery on June 24th, 2025. I'm Dr. Ara Deuk-Majan, CEO and founder. Our patient comes from Colorado to Florida because she has two herniated discs in her neck. She's been suffering with neck pain and radicular symptoms down her arm for 15 years. She needs surgery to fix the problem. Herniated discs that are symptomatic need surgery to fix them. She has a choice. Go with an ACDF that all the other surgeons are telling her to do. Go with artificial disc replacement. Or go with the most advanced treatment in the world, endoscopic Deuk laser disc repair. She educated herself on the pros and cons of each treatment. She realized that fusion, ACDF, and artificial discs are highly invasive and destructive, destroying skin, subcutaneous tissues, fascia, muscles, voice box, swallowing tube, all that affected by those invasive surgeries permanently with permanent problems and disfigurement. But she found the Deuk laser disc repair, a less invasive, safer, and more effective treatment that addresses the herniation without removing the disc, without putting metal or any other implants in the body. So she came here to Florida after doing a Zoom call with me, and now we're going to fix C4-5, C5-6. Everyone agree? She's somewhat supple, maybe a little more muscle relaxer. What do you think, huh? Yeah, let's do that. So she's laying on this operating table looking up at the camera. Her face is covered by plastic. Her body is here. This is the left side of her neck. To access the spine, Ariana, come on over here. Don't be shy. This is your spot right there. Just don't touch the blue. Okay, you can come right here. You can be about a foot away. To access the spine, which is deep in the neck, I have to get past everything here in the front, and I got to do it safely because there's lots of important things here, like the carotid artery, the jugular vein, the vagus nerve, the esophagus, the trachea, other superficial veins and muscles. But we're going to go in with a small needle. Tell me when. It seems like it's more supple. Yeah, it's more supple. So we just gave her a little more muscle relaxer. What happens is if you don't give patient muscle relaxer, you push here, the muscles tighten up in response. They react. And it makes it harder for me to do this. So we gave her some more muscle relaxer. I can feel her spine with my fingers. You got to use two fingers, spread them apart, and go between them with the needle. Now this treatment you're watching is being performed here at Deuk Spine Institute. 2, 3, 4. So we're at 3, 4. You agree? Too high. We want 4, 5, 5, 6. Everyone agrees? Remember, she's had problems for now 15 years. She comes from Colorado. They have lots of spine surgeons there, but none of them perform the Deuk laser disc repair. 2, 3, 4, 5. So I'm right over the 4, 5 disc, which is, you say, is good because you got to treat it. But I really want to be over the C5 vertebral body because that's the one that's between the two discs that we're treating. All right, 2, 3, 4, 5. So I want to be a little bit further south. And then I can kind of wiggle things and move up and move down. Shot? All right, that's perfect. So we're going to start, where do you want to start, Luis? 5, 6? So I'm going to pull down and start at 5, 6. Shot. There it is. You can see the needle hovering over the disc space. 2, 3, 4, 5, 6. I'm going to go down to the spine. Shot. I'm going to place the needle down there right now. Shot. There it is. You guys see that? The needle is sitting in front of the disc. AP. I want to check my AP to make sure I'm in the middle. You don't want to be off to the side. Shot. That looks pretty good to me. It looks like the tip of the needle is in the middle of her disc. Shot. You guys see I've displaced the trachea and esophagus to the side.
Yes, we do.
Shot. I'm going to flip the needle and go the other way. Enter the disc. Shot. We're just inside the disc now. Shot. All right, we're just inside the 5, 6 disc. You all see that? Take a look at that. Show us the tip of the needle, Jordan. Thank you. We're in the middle of the C5-6 disc. Let's count. 2, 3, 4, 5, 6. Remember, number 2 is the tall one. Let's get an AP view. How's blood pressure? We're going to just verify that our needle is in the middle. But so far, everything's going well. This entire surgery will be done with a 4mm incision. Yeah, that looks pretty good. I might be able to come a little bit more to my side. So, I think we're actually okay. Yeah, we're okay. We're going to do our discogram. Now, folks, with the discogram, you're going to see dye injected into the middle of the disc. You're going to see a tear. Sean? You're going to see a tear. Look at that tear right there. The dye is leaking out the back. Show us the tear in the back of the disc. There it is. You see the black dye is filling the tear.
Yes, we do.
That is where the herniation is coming out. Show us the herniation. You can actually see it right there. It looks like a boob, just kind of on the side view of a breast hanging there. So that is the first herniation we're going to go after today. Any questions from our audience?
Yes, we have a question coming from Lanu on YouTube.
I'll do one quick question and then we're going to show everybody all the different causes of neck pain because there's about 30 things that cause neck pain.
Lanu asks, is there a connection between herniated discs and heart?
The heart.
Correct.
Yeah, of course. The herniated discs that cause pain can definitely affect your heart rate and your blood pressure, right, Dr. Berndes? We see it all the time. Pain can go to your brainstem, and when the pain is in your brainstem, it will affect your brainstem nuclei that control heart rate and blood pressure. So yes, herniated disc can affect your heart. Shot, look at that. The guide wire is inside the disc. You guys see that? The guide wire right there.
Yes, we do.
I'm going to take this dilator and I'm going to run it right down the guide wire. Okay? You guys see the dilator? It's very skinny. It's got a tapered tip. It doesn't cut anything inside the patient. The only cutting I did was her skin, and it's literally a 4mm cut. It's tiny. So I'm going to advance this down. You're going to see the dilator right there. It looks like a metal pencil shot. Now I'm in front of the disc, right? So here's where I'm going to make a little bit of a correction. Let's get an AP view. I may want to move it towards me just about a millimeter or two. I just want to look at it. So the ideal position is going to be anterior to the spine on the anterior longitudinal ligament, or ALL. You want to be between the longest colli muscles. All right, so yes, I'm a little bit off to her right. You can see the dye leaking out the foramen on both sides. Show us the dye. See the tear right there? Show us the tear. Yes, that's the tear on the right. See the dye?
Yes, we do.
That dye is wrapping around the nerve root right there. That's what the nerve root is. Now go to the other side. You can see a tear on that side with the nerve root. So she's got a broad-based tear on both sides. Yeah, go ahead and go back to a lateral. I'm going to take the guide wire out. I'm going to move the dilator to me just slightly. Tell me when you're ready, Jordan. Folks, the whole surgery, we're going to lose this much blood right here. A few drops of blood. That's it. All right, so I'm taking the guide wire out. Shot. I'm going to move this dilator towards me just a little bit. Shot. All right, just a smidgen. Let's get an AP. I'm sorry? I don't need any inline. Sean? I'm going to re-verify. All right, so stay there. I can move a little bit more towards me. Shot. Wait. I don't want to radiate my hands. Shot. All right, that looks pretty damn good. I'm happy with that. We're on the medial border, the longest colli. I got to verify my position on lateral view, but so far it looks pretty good. I'm pretty close to the center. All right, I'm very happy with that. Shot. All right, just give me a little extension on her neck. That's enough. Shot. I'm going in. We're going through the front of the disc. We're going to go all the way to the back where the herniation is. Shot. All right, looking good. Got to be very careful. This is very delicate work because the spinal cord is just right back there. You don't want to hit the spinal cord. The Koreans did that a few times. They paralyzed a few patients. We're not going to do that to our patient. Now, the whole surgery is done through this tiny metal tube. Again, this is the only place in the United States I know that's doing anterior cervical transdiscal surgery like this. and everybody else is slicing the patient's necks open and causing all kinds of problems for the patient. And by the way, those problems that those surgeons cause through open surgery, they're like, yeah, it's just part of the surgery, right? So what? Oh well. It's kind of like those warlords in Africa where they go in a village and they kill all the people, the children, they turn them into mercenaries. They shoot people and kill all the elderly and, good people. And they just say, yeah, it's part of taking over the country, doing the right thing. No, it's not. It's horrible and horrific. Nobody should have to undergo open surgery anymore on their neck when we have this minimally invasive endoscopic surgery. The problem is your surgeons out there are too lazy or too arrogant and too greedy to learn a new technology for their patients to do what's right for their patients. Instead, they want the big fusion money that you get paid when you do fusion surgery. They're in cahoots with the industry that manufactures all the metal plates and screws and cages, and the two of them are getting very greedy and getting very rich off putting metal in patients' necks and backs. Shot. We're not putting any metal. This is just obviously surgical instruments. All right. We're not making much progress. It's very slow. Maybe I do need a little bit of inline traction, Dr. B. Let me know when you're ready. All right, I'm just checking this out. Everything looks good. Now her right arm was the main problem, which is why we're going from the left side. All right, we made a little progress there, Sean. A little more there, Sean. We're almost there to the back of her neck, or back of her disc. Seems to be some resistance here, which is probably scar tissue if I had to guess. That looks pretty good. Let's go with that. Any questions?
At this moment, no current questions.
Show the 30 causes.
Of course.
Go ahead, go. I'm Dr. Deuk Majan, CEO and founder of the Deuk Spine Institute. We're going to talk about the 30 causes of chronic neck pain. Chronic neck pain is neck pain that lasts longer than 6 weeks. There are 30 causes to chronic neck pain. The most common cause is the disc. There are 6 discs in the neck. These discs can become injured. The first disc is C2-3. Next is C3-4, C4-5, C5-6, C6-7, and C7-T1. The most common disc to be injured and cause neck pain is C5-6, followed by C6-7, followed by C4-5. The other discs rarely cause pain. Discogenic pain represents 85% of chronic neck pain. Next, the facet joints cause 10% of chronic neck pain. Facet joint pain is very common in patients with neck injuries and spine injuries. Facet joint pain is usually located on the sides of the spine, either right, left, or both. Facet joint pain gets worse with rotation of your head and neck, worse with extension. The most common facet joints to be injured are C5-6, C6-7, and C4-5. C7-T1 is another common facet joint to be injured. These joints, after injury to the capsule, will develop arthritis. It is the arthritis in and around the facet joint that causes the neck pain and stiffness with movement. Deuk plasma rhizotomy is the best treatment in the world available for painful facet joints. Deuk laser disc repair is the best treatment in the world available for painful discs. Other causes of chronic neck pain include fractures, tumors, infections, and muscle spasms. These other causes represent less than 1% of chronic neck pain. Thank you for joining us for 30 causes of chronic neck pain. All right, you're welcome back. You can all see from our video there are about 30 things that cause neck pain. They include disc herniations, facet pain, tumors, fractures, infections. But if you want to know what's the most common cause of neck pain, it is a herniated disc, but it's specifically a tear in the back of the disc called an annular tear, posterior annular tear. Remember, the annulus wraps around. Annulus in Latin means ring, It's a ring of dense connective tissue wrapping around the outside of the disc. The inside of the disc is this blue stuff. It's called the nucleus pulposus. And right here, this stuff is part of the herniation. It's escaping out of the disc through the tear. I showed you guys the tear just a few minutes ago on the x-ray. You can see that the annulus is torn, the ring is torn, and because it's torn, it's letting the blue stuff escape. That's how you get a herniation. So to get a herniation, you have to first have an annular tear, and then you've got to have pressure on the disc, and then little pieces like this blue piece right here that I'm zapping with the laser, that squeezes out from the middle, and it gets stuck inside the tear. And then it creates inflammation, which is very painful. It's like a zit. If you've ever had a zit on your face, you know how tender, you know it's raised and swollen, you know it's red, and that it's tender and hot. All those are characteristics of what we call inflammation. So it's the inflammation from this tear and the herniation stuck in the tear that causes all the pain for the patient. Right now I'm using the laser to remove the herniation, but the spinal cord is right behind this, so you have to be very precise. And it turns out the laser is the most precise instrument in all of medicine currently. It's extremely precise. The only thing more precise than this is going to be drugs. Drugs are microscopic molecules. They travel throughout your body. They go to specific targets where they bind to receptors or they affect the intercellular machinery of your cells. They are smaller than, they have a smaller effect or smaller size than the laser does. But the laser is the most precise, smallest, most accurate surgical instrument there is, okay? Any questions?
Yes, we have a few questions. Next one is coming from Majid on YouTube.
Hello, Majid. Welcome to our live stream at Deuk Spine Institute.
Saying, hello, are there any studies for assessing long-term result of the DLDR? Regards.
Yeah, so getting studies published today is almost impossible. You have to be connected to a university, or specifically you have to be connected to a company that manufactures and sells surgical implants in the spine world. So in the spine world, the big money makers for companies are metal plates, cages, spinal cord stimulators, and devices. They're called devices and biologics. Biologics are like cadaver bone that's been processed and sterilized, and it's sold to be put in during fusion. So these device companies now control the education of surgeons. They control the publication of peer-reviewed journal articles, and they control the scientific meetings that surgeons go to every year. They control all of it through funding, through money. They're very, very wealthy, and they've assumed control of all these outlets. One of them is publication. So the problem is, because this surgery doesn't use any devices that they're getting rich off of, they block the publication of our procedure. So no, we're not going to have publications. We have a few, yes. They were made years ago, 12, 13 years ago, but we're not going to be getting too many more, because now these companies are on to what we're doing, and they don't want this surgery becoming more popular. They want people forgetting about this surgery, and I'm not going to let people forget about it. Because this, oh, look at the herniation. This is a far better surgery than open surgery. Look at the herniation right there. It's sitting on the nerve, literally crushing the nerve. The nerve is just below it. See how I'm zapping it away with the laser? There is no surgery in the world more effective and safer for patients than this laser surgery. This is incredible. 99.999% of spine surgeons have never seen this before in their life. And they're the most trained people in the world on doing spine surgery. That's because this is a very special technique. Look at that herniation. It just rolled right out of the foramen. See it? It's all collagenized. That means that the body's inflammatory system has been working it over, like punching it, beating it up, but scarring it up, so it's hard and calcified. Look at that. Hard and calcified. So it's not coming out easily because it's scarred down. So I got to use the laser to free it up. So yeah, there's not a lot of publications because the journals are now controlled by the mafia of spine surgery, and that is the big implant companies. They're not going to let my surgery get out there. They don't want more publications. They want less. They want you, the public, to forget about this surgery and not even know about it. But we're not going to let that happen. That's not right. Great question, though. I appreciate it.
We have a couple more questions.
Sure.
Next one is coming from Kit on YouTube, saying, Dr. Deuk, could you explain T-lift remove facet only one side good or bad? My doctor said my spine curvature is fine, so no need to do a full laminectomy for T-lift. Is that true?
Well, it's a great question, Kit. So when I do a T-lift, I always take both facets out on both sides. If you watch my surgery, you'll see me do that. Why do I do that? Because the vast majority of patients I do T-lift fusion on, they have a deformity where they're kyphotic at that segment, and I got to take the facet out in order to reduce their deformity and put them back in lordosis. The other reason I take the facet out is every patient I operate on with the T-lift has leg symptoms. They got leg pain, weakness, numbness, tingling in the legs. So of course, I got to get the pressure off the nerve root, and the nerve is usually being pinched by the facet. So when the facet gets large or hypertrophied, it starts pinching the nerve root, which is literally in the lateral recess just in front of the facet. So you've got to remove the facets on both sides if you have any nerve root symptoms from pressure on the nerve roots. Okay, I do it every single surgery. It's hard. It takes extra effort, but surgeons don't like to do it because it's extra work, and they don't get paid for it, by the way. You don't get paid for that extra work. So you're doing extra work, could be an hour extra work, and they're not being paid for it, okay? So to get the payment for a Smith-Peterson osteotomy, which is removing your facet joint, all you got to do is take part of one of them out, and then you get the full payment. But taking two of them out doesn't give you any extra money. So a lot of surgeons make decisions based on money rather than what's best for the patient. Deuk Spine Institute does not. We always do what's best for our patient, not what's best for our pockets, our golf game, our Mercedes payments. We do what's best for our patients. That's the Deuk Spine difference. Great question. I would want to have both facets out, but the truth is, if you want my honest opinion, you need to do an MRI review. All right, look how scarred up this herniation is right here. It's like literally just sitting on top of the spinal cord right there. It doesn't want to move. It's just sitting there right on top of the nerve root and spinal cord, and I've got to zap it away. It's all scarred up, scar tissue. That's the white stuff. Okay, very hard to get out. It's not coming out on its own. I've got to zap it out with a laser. Any other questions?
Yes, we have a couple more questions. Next one is coming from Justin on YouTube.
Justin, my man. What's
Sa-
up?
Saying, hi, Dr. Deuk.
Hi.
RN in VA working with post-op ortho/spine patients. Love your videos and surgical live streams. Deuk laser spine surgery is truly innovative with great outcomes.
Thank you.
You inspired me to pursue the surgery I once dreamed of becoming. The surgeon I once dreamed of becoming. Would you recommend neurosurgery or ortho spine? How do training and outcomes differ in your opinion?
Yeah, great question. So if you want to be the best at spine surgery, you need to be a neurosurgeon, okay, period. Why? Here's the main reason why. When you do neurosurgery training for residency, it's 7 years, but every day you're going to do spine surgery, okay? If you're an orthopedic resident doing orthopedic residency, you're not going to do spine surgery unless you go to a rare program that lets you do spine surgery. But here's the reality. The majority of spine surgery at university hospitals is controlled by neurosurgeons. The neurosurgery department has admitting privileges for spine patients. So the orthopedics usually do not. So neurosurgeons have taken control of spine surgery in the last 30 years, and very few orthopedic departments have admitting privileges for spine. So if you're going to make an assessment, you need to look at the program and say, you know, if you're thinking about orthopedics, you got to say, all right, how much spine surgery do you guys do every day of the week? And if they say, well, we don't do spine surgery, the neurosurgeons do it, you don't want that orthopedic program, right? Because you're not going to learn spine surgery there. Wow, look at that herniation right there moving. On the other hand, if you do neurosurgery at a good residency program, you're going to learn spine surgery because neurosurgeons have the admitting privileges and do the most spine surgery. And you're doing spine surgery for 7 years rather than being an orthopedic surgeon who just does it for 1 year after you're done with your orthopedic training. Okay? So, my opinion, you want to be a spine surgeon, you want to be good, you go become a neurosurgeon.
We have a couple more questions.
Sure.
Next
But
one.
before we do the next
Yes.
question, we haven't shown our video on how look at that herniation just rotating there. I'm zapping it and it's starting to roll like a little rock, sitting right on the nerve there. You see that?
Yes, we do.
We're going to get it, don't worry. It's just scarred in there pretty good. Very difficult case. Remember, she's from Colorado, 15 years of pain. I did a Zoom call with her, diagnosed her problem, and now she's here with her hubby, getting the very best surgery in the world for her herniated disc. Let's show the audience how the Deuk laser disc repair works.
Of course.
Disc injuries start with an annular tear. Damaged nucleus pulposus herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website at www.deukspine.com or call us at 1-800-FIX-MY-NECK 349-6963. Disc injuries is a common cause of chronic neck pain. The inflamed annular tear causes neck pain. A 4mm skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes herniated disc fragments and debrides the posterior annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website at www.deukspine.com or call us at 1-800-FIX-MY-NECK 349-6963.
Welcome back. So you've seen on our video how the Deuk laser disc repair works to get rid of the source of neck pain, which is the disc herniation, annular tear. It also can remove herniations that are pinching the nerves and spinal cord like we are now. Now, the beauty of this surgery is, number one, we don't make any big incisions. Everything is small. Plus, we're not damaging anything inside the neck. This is all just the back of the disc that we're actually removing the herniation from the tear. That's the blue stuff we're removing, is the herniation. Now, if the herniation's been there a long time, it gets scarred and it turns white. You guys saw some of that earlier, scarred up white herniation. Any other questions?
Yes, we have another question coming from Majid, once more on YouTube, asking, this is an amazing new technique for removing discs. Do you have fellowships in your institute?
We're going to have fellowships. I will train surgeons in the future, but right now I'm not training anybody. But thank you for asking. Yes, we will have fellowships at Deuk Spine, but the fellowships are going to be designed to train doctors who want to work at Deuk Spine, not just go out and do surgery elsewhere. I'm not interested in training surgeons to do my surgery when they go out and mess people up. So I want it under my control, my supervision. I'm actually, after all, the pioneer who designed this surgery. I want to make sure it's done right. In the end, we're operating on people, and people, the results are very important to me. I don't want bad results with my treatments, my surgeries. So I will be training people in the future, but they will be my doctors who work for me at Deuk Spine. Oh, look at that herniation. You guys see that thing just come out?
Yes, we
I'm
did.
floating it up. It's probably about 3 millimeters piece. It's not big. It came right out of this hole over here. Just about done with this disc, and then we're going to move on to the next disc. I got about 5 minutes, Dr. Berndes, on this disc. That's fibers of the posterior ligament right there. All right. Looking in the foramen, see if there's any more herniation. Any other questions?
Yes, we have another question coming from Lanu, once more on
Lanu,
YouTube,
sure.
asking, do airports have a doctor? I often hear there are medical emergencies at airports.
Airports do not have doctors typically in America, but sometimes there are doctors traveling, and if patients have or people have emergencies on the plane, a lot of times doctors will jump up and volunteer to help. I know I've done that many times as I travel around the world. This is all scar tissue right here. You guys see all this?
Yes, we do.
Amazing, huh? How much scar tissue there is. This just white chunk of scar tissue. Amazing. You can see the posterior ligament there. It's calcified. And I'm only zapping this. I don't think it's compressing the spinal cord anymore, but it could be causing some pain. And there could be a trapped herniation underneath. I think we're just about done with this disc. Oh, another herniation. You guys see that thing come out?
Yes, we
Now
do.
that's a newer herniation. Why? Look at the edges of it. It's frilly, like frilly, you know? And also it's not as calcified or scarred up. So it's kind of a fresher herniation. This is kind of a new herniation, probably in the last 6 months. If I had to guess its age. Right there. Trying to get it out. It's just kind of starting to calcify, so it's a little dense. It doesn't want to float up and out. So if I take more of it and make it smaller, it'll probably float up. Here it comes. All right, so we just floated it up and out. Goodbye. Good riddance. All right, just about done. Let's see if there's any more of these hiding herniations. They're like little terror cells waiting for us to leave so they can wreak havoc on the patient. But everything's going well for her. She's stable. She's under general anesthesia, completely asleep. And I have the best anesthesiologist in the world working with me, Dr. Berndes. Any other questions from our audience?
At this moment, no current questions.
All right, I'm very happy. You can see the spinal cord right there. You guys see through that crack?
Yes, we
That
do.
whitish thing is the spinal cord. And the reason it's red is because of inflammation. Remember we talked about that. So now that we got rid of the herniation, that's going to go back to being normal looking. It'll take a few months. Flip it. Just about done. This was a lot worse than I expected. This has taken a lot longer than normal, but we stick it out for our patients. I don't have a tea time today, so I'm going to stay here and get everybody's surgeries done right. Any other questions?
At this moment, no current questions.
All right. Just about done here. About 30 seconds more, hopefully. I'm pulling back the tube. Looking. There's a few more loose herniations. They're not bad. They're just fluffy little ones. Flip. Most of them are coming from her left side, which is not really her symptomatic side. But I guess they would have started causing problems for her in the future. All right. So I'm going to tell you, we're going to take this tube out in a moment. We're going to move it to the next disc, and we're going to do the next disc. So far, everything's going well here. All right. All right. Let's see. Just look over here. Another little piece. Just floating it out. We float these out, okay? There's a lot of water, sterile saline, circulating through here. I'm having trouble with her chest. If a patient has a really big chest, it makes it hard for me to move the tube and get to where I need to go. It's one of the anatomical constraints of surgery is you're sort of limited by your patient's anatomy, okay? Golly. And people with a big chest, there's not much we can do. We do the most we can. She's got a big chest, a kind of a barrel-y chest, so it makes it a lot harder to do the surgery. But so far, I'm very happy with our results. You can see the nerve down there. I think we're done here. All right. We're going to take the scope out, turn the light on. So remember, in the front of the neck, 4 millimeter incision, tiny, tiny Band-Aid incision.
I'm gonna need a towel here. I got a lot of water.
That's correct.
I need a 20 cc, please.
Oh, just save it. You don't need it. We'll just put my thumb over it next time. All right, irrigation. We're irrigating. No, we don't. What do you got? Irrigation there? Found its way over to you, huh? Berndes? Are you sure you didn't have a bladder issue? Right? Neurogenic bladder. All right, folks, check it out. Yeah, you're right. So there's the 4 millimeter incision. We lost like literally 10 drops of blood maximum. Now let's bring the fluoro in. What I'm going to do here is I'm going to take the tube out but keep the dilator in. And then I'm going to move the dilator up to C4-5. We're going to do that disc next. Now this movement from one disc in the neck to the other, I created that. I was the first in the world to do it. The Koreans never did it. They always did one disc at a time. And they'd make the patient, if the patient had 3 herniated discs that needed surgery, they'd make the patient come back 3 times. This was, 20 years ago, of course. But I was the first, about 19 years ago, to slide along the ALL from one disc to the next. All right, you see the tip of the dilator? I'm going to pull this out, this tube out. Of course, it disconnects rather than comes out. So let's see if I can do that shot. Perfect. So I'm bringing the tube out, leaving the dilator there. All right. So we call this the Deuk spine slide, right? The Deuk spine slide. We haven't patented the name, but it's the Deuk spine slide. So I'm going to pull the tip out of the disc, and then I'm going to slide it along the ALL, anterior longitudinal ligament. Shot. Here we are. We're right outside, and now I'm on the ALL. I can feel it. Shot. So you see that? I'm a little bit off to the side. I got to figure out which side I'm off to, because I got to fix that right away. You don't want to ever just do this based on one view. You got to use 2 views. All right, so I'm off to her right. I need to come back to the left. Hold on. Man, that is not easy. Shot. Uh-huh. Am I back in the disc? Shot. So I'm staying off to the right. Give me a lateral view. I've got to fix this. I'm not happy with it. Shot. AP. Hold on. Let me see if I can fix it right now. I'm slid off of the bone and I'm off to the right side. So I need to fix it. And it's not happening. There we go. Shot. All right. So let's get another AP. I may have gone to the left side now. So I may have slid right across the face of the spine to the left side. Quick shot. Come on. Quick shot. Yep, I did. So I'm off on the left side. She's got very pointy vertebral bodies, and they're making me it's like the top of a pointy roof. I'm either going to slide to the right or the left. But there we are. We're dead center. See that, Ariana? Dead center? Yeah. Jordan, show us the spinous process. They're on the back of the spine, but they mark the center. There's the spinous process. There's this right there. So I'm in the center. All right. You always look for those to tell you if you're in the middle. Lateral. All right. We're right below the disc that we want to go into, which is C4-5. So I'm going to slide up. There we go. I just slid. There it is. You guys see that?
Yes, we do.
All right. So I'm sitting in front of the disc. right against the front of the disc. I can go a little bit more up, a slight bit. Oh, that's too much. Shot. Yeah, right about there. All right. Now, give me an AP view. I want to verify I'm in the middle. So I moved again. Every time you move, you must recheck lateral and AP. All right, so I slid to the right again. You see that? I'm too far to the right. So I got to come back again to the middle. That's why you always double check. Always. That's perfect. I'm dead center right there. Dead center. Okay? You can see the spinous processes, and that tells me I'm center. All right, but I moved up onto the bone now. 2, 3. See? Look at that, Ariana. I'm on top of the bone. So I got to come back down to the disc. So she's got some weird disc anatomy that's forcing me to kind of slide around a bit. She's not making it easy. If I was a roofer, I would have fallen off the roof by now. All right, give me another AP. Shot. Quickie, quickie. All right, lateral. It's perfect. Hold the neck. Give me a little inline extended. Any questions? Sean?
Yes. This next
2,
question.
3, 4, 5. Everyone agree 4, 5.
This next question is coming
Sean?
from Lanu, once more on YouTube,
Uh-huh.
asking, does this patient have numbness on
All
her
right,
hands?
perfect. So I'm in the middle of the disc. I'm going to do another discogram. Does she have numbness in her hands? I don't know. Does she?
No, she has
She does not.
problems with shoulder pain.
I got it.
Shoulder issues.
She has pain radiating from her neck into her shoulder. Shot? But she does not have numbness in her hands. We're going to do another discogram. We're going to inject the blue dye, the Deuk spine dye. All right, here we go. You're going to see a tear. Watch this. Injection, shot, and there's the tear. Show them, wow, that's a big tear. See the tear right there, guys?
Yes, we do.
That black sausage is a tear. And that's where the herniation came out. Shot? So I want to move the tip of my dilator right, look at that. See how the tip of the dilator is inside the tear? I'm literally inside the tear. And that's exactly where we want to be. This is perfect. Now, as I put the tube in to do the surgery, you have to watch the dilator and make sure the tip does not go backwards. If the tip goes backwards, then you're going towards the spinal cord, and you can paralyze the patient. So it's very easy to paralyze somebody with the surgery if you're not paying attention and checking. Again, I've never paralyzed a patient in my entire career. I've been a neurosurgeon for 29 years. But you can see the dilator is moving backwards. So that's good. I'd rather go backward than forward. Nope, we're fine. I'm going to reposition the dilator by putting it forward a smidgen. Shot? By the way, I got lunch for everybody again today. You're welcome. I'm going to surprise you with the lunch, something you've never had before. Brooklyn pizza. Have you ever had that? Brooklyn pizza?
Yeah, I told you.
I'm just kidding. You know, I buy it every week. I guess we can go back to doing Moe's or Chipotle or something, but I got to get my pizza fix. All right. All right, so here we are. We're about as far back as we want to be. That's pretty much perfect right there. The Stromboli, yeah, no, I order the Stromboli now every time. Look at that tear, guys. That is a perfect picture of a tear, Henry. You see that?
Yes, we do.
That would be great for the website. How
Perfect.
we use the laser for the annular tear. If you could keep that picture, Henry.
Copy that.
And it's a cervical posterior annular tear intraoperative. All right, just leave it.
Copy. Got it.
Is this the good tubes? All right. Remember, we're doing all this through a 4mm incision without opening her up. Therefore, we've never had any problem with swallowing or hoarseness like other surgeons get when they do open surgery like fusion or artificial disc. Wonderful. So I can tell you right now, this disc is a newer herniation. The other one was an older herniation. This is newer. I can already tell by the way the disc looks. It's a fresher herniation. Kind of like when you look at a a piece of steak in the grocery store. You can kind of tell when it's old. You know, it starts to change colors. But the fresh steak has a different appearance and texture. So the disc itself has a different appearance and texture. And when you look at enough of these things endoscopically, you get really good at figuring out how old the herniations are, which is actually very useful for car accidents. You know, patients who have a car accident and they have a herniation, I can get in here and look at it and I can kind of give it an age, how old that herniation is. It's more accurate than an MRI scan. Any questions?
Yes, this next question is coming from Justin, once more on YouTube,
Hello, Justin.
asking, what are your thoughts on spinal cord stimulators? Do they sometimes do more harm than good?
Spinal cord stimulators are horrible. They are the best example of the medical device companies taking over healthcare for profits. Okay? They're horrible. Spinal cord stimulators, I was trained to put spinal cord stimulators in during my training. Neurosurgeons at the University of Florida in Gainesville, we used to do spinal cord stimulator implants for patients that needed them. But I'm going to tell you what's happening. Spinal cord stimulators were originally prescribed and given to patients with severe diabetes that had peripheral neuropathy, or they had chronic radiculopathy, where they had nerve damage that could never be fixed with surgery. That's the two types of patients that got it. And then, of course, reflex sympathetic dystrophy came along. We started doing it on them. Those are appropriate patients. Severe neuropathy, chronic radiculopathy that's not fixable with surgery, and reflex sympathetic dystrophy. Now, what happened is those are a very limited number of people. That's probably like 50,000 surgeries a year right there. The companies that make the stimulator, like Boston Scientific, are so greedy with the profits they were making. They were making about $20,000 a surgery profit. And they were doing, like I said, 50,000 a year. So they were making billions of dollars profit. So what they did over the last 30 years is they've expanded the indications for stimulator. What does that mean? That's a medical term called expanding the indications. It means that instead of just reserving it for patients who really need it, they open it up for patients with any kind of pain in their back or legs. And now, of course, the doctors who are putting them in are getting huge profits for putting those things in, bigger than any other surgery they do. And they're recommending it to every patient they can because of the profits they're making. And yet they don't work. And if they do work, they stop working after a few months. Okay? So I am 100% against spinal cord stimulators for anything other than reflex sympathetic dystrophy, diabetic neuropathy or neuropathy that's chronic and debilitating, or chronic radiculopathy that cannot be fixed with surgery, like decompression surgery. So they're way overprescribed. They're doing probably about 1 million a year now. They went from 50,000 to 1 million. And remember, it's all driven by greed. They just want to make money. The surgeons want to make money. The implant companies want to make money. They don't actually care about patients, and the procedure doesn't work. But here's their thinking. You know what? Nothing else works, so why not just do it, right? It's another treatment that doesn't work that we can have our doctors recommend and do, and we can make a lot of money doing it. So we got to get away from this philosophy of doing treatments that don't work, because now we have treatments that do work, like the Deuk laser disc repair. All right, great question. I hope I answered it. Henry will put the website page on our website for the spinal cord stimulator where we talk about it. Let's flip. This is our last disc. We're going to be done in 10 minutes, Berndes. 10 minutes or less. And we're going to move on to the next surgery. Our next surgery is going where? Right here. So the next surgery is a lower back patient that we're going to be doing. Wow. By the way, this is scar tissue at the back of the disc. Okay? And this is posterior ligament, posterior longitudinal ligament. And it looks like there's a tear right there. You guys see the tear? And that looks like spinal cord right there below it. So this is herniation. And it looks to me like that could be spinal cord right there, because you know spinal cord because it's white, plus it has little veins on the surface. So we want to be super careful with that, not to damage it in any way. And I'm going to look around a little more, but like I said, this herniation is newer and it's not as pronounced as the other one. We just got to be really careful. But you can see very well everything, the anatomy, with the endoscope. The endoscope is very, very good at allowing the surgeon to see things better than any other technique. Microscope is not as good, and then loops is not as good as a microscope. So of all the techniques surgeons can use to see the herniation back here, the endoscope is the best. It's the most sensitive. I'm going to look out the foramen here. There's some herniation there, the blue stuff. Try to zap it away. Any other questions? Because we're almost finished.
Yes, we have about 2 more questions. Next one's coming from Majid once more.
Before we take that, just look at this here. We are literally zapping the herniation right off the spinal cord. And you see the inflammatory tissue right there, the red stuff? That's blood vessels like an inflamed pimple. Okay, that shouldn't be there. It should be white. There should be no red. So that's abnormal. It comes from inflammation. Remember, it's inflammation at the back of this disc, right in the tear here, that causes the patient's symptoms. So I got to clean this up, and hopefully that'll take away all of her symptoms. Yes, Majid.
Asking, is there risk for reoccurrence of the disc?
Yeah, so Majid is saying, is there a risk that you could reherniate the disc? Yes, there is. As a matter of fact, the reherniation rate with this surgery is 1%. It's been 1% for about 19 years now. I'll be honest though, we haven't had any recent reherniations, so it seems like lately it's gotten better, but it is 1%. All right, we're just about finished. And this is more of a bulge here at C4-5 than a herniation. But you can see this needed to be done. All this swelling and inflammation, bad. Yes, any other questions?
Yes, this next one is coming from Cassandra on YouTube.
Hi, Cassandra, welcome to our stream.
Saying, hello, doc. Can you do laser surgery on stenosis if the patient has a fusion?
Yes, we can. We can, but I need to do an MRI review to make sure I can get in to the area you need me to get into. And that's going to be looking at your MRI and understanding your symptoms. 5 minutes. The reason I'm telling my anesthesiologist how much longer I need is because he has to wake this patient up. And to wake the patient up, he's got to turn off the anesthetic gas because it's the gas that's keeping the patient asleep. So he's going to have to shut it off, and we do, it's called a reversal of anesthesia, where the patient comes out of anesthesia and wakes up, starts breathing on their own. Okay? So that's why I'm telling my anesthesiologist how much longer I have, because he needs to know so he can safely prepare the patient for reversal. All right, any other questions?
At this moment, no current questions.
So to answer her question, yes, we can do the Deuk laser disc repair to treat stenosis, as long as it's not at the fusion level, as long as it's above or below the fusion level, which I suspect it is, but I need to do an MRI review to verify that. All right, folks, type in your questions. This is just about done. I got about 3 minutes left and we're going to be finished. I'm going to show you the incision. It's only 4 millimeters. 4 millimeters, folks. That's like a 1/6 of an inch. It's tiny. And we've had no bleeding, as you can see. There's no hospitalization required with our surgeries. Our patients basically go home. And in the case of people traveling like we have today, we have patients from Colorado, North Carolina, Canada, Ohio, where else? We have people from all over the world today and all over the country. They all come to Deuk Spine for this laser surgery and basically to get out of pain. Last piece right here, and then I'm going to just double check everything one more time. Pretty happy with that. Gonna peek on the other side one more time. I like to check and double check and triple check and quadruple check. As a surgeon, you should always be double, triple, quadruple checking. You have somebody's life in your hands. It's very important you treat them with the utmost respect and care. You always do your very best for them. All right. Let me just see I just see a trail of blue right here. I want to just see if I can get it. As much of it as I can. Any other questions, Hen?
At this moment, no current questions.
All right. Pretty happy with that. We're done. Now, one thing patients don't really understand sometimes is we're not going to make her disc look normal. There is no surgery in the world that makes a damaged disc normal looking. Okay? What we want to do is make her disc feel normal. So get rid of her pain, get rid of her inflammation, and make the disc feel normal. Hope that makes sense to you all. We're done. Any other questions?
At this moment, no current questions.
All right, let's take a look here at what we got. I want to show you guys this whole surgical incision. You guys see this? This is the front of the neck.
Yes, we do.
And I'm going to pull this out and break it down. Okay, that's a suction line, by the way. That's why it sucks. So take a look at this. Here's a tape measure. And there's millimeters right there. You guys see that?
Yes,
and that
we
is
do.
a 4 millimeter cut. That's it. That's why people don't have any problems with the surgery afterwards. It's safe, it's effective, much more effective than open surgery, and the recovery is literally an hour, and they're back to a normal life with some minor restrictions. Thanks for joining us. Let's leave our audience with one of our patients who had this procedure done.
Of course.
Good job, everybody. Thank you. And good morning, I'm Dr. Deuk Majan at the Deuk Spine Institute. I'm here with my patient who traveled to Deuk Spine Institute with a couple of problems. She had neck pain from a herniated disc and facet joints, and we fixed both yesterday. She's here less than 24 hours after her surgery. She went home, back to her hotel with her family afterwards, and she came back in for a quick checkup. You can see the incision for her surgery is 4 millimeters. It's tiny. How do you feel today?
I feel good. A little sore from surgery, but that's normal. I'm so much better. I could just feel that I've been fixed, and that was not gonna happen without you.
Well, how did you hurt your neck?
I got into a motorcycle accident back in October, and it flew off the bike.
And you've been suffering since then.
Yeah.
Why did you decide to come to Deuk Spine Institute?
Do you have enough time?
Sure.
I came here because I was told that I had to have this really invasive surgery. They wanted to do a discectomy.
And fusion.
Yeah, and I was very scared. I was very scared, especially after reading what could happen, the risks. It was just too much, and actually kind of scary, because when I looked into the doctor, he actually had a lawsuit against him, which the people who suggested him to me were not aware of. So I kept doing my research. I thought, well, maybe I'll just figure out how to do some exercises to help my herniated disc, which, yeah, now that I know what I know, that's not gonna help your herniated disc. Nothing is gonna put that stuff back in your disc.
That's right.
So I did 6 months of physical therapy. That was unsuccessful. I still had pain in my neck, and it was really bad. I would turn my head anyway, and I would always feel the pain right here, feel the pain in my C6. I couldn't do the things I normally did. So when I did my research, trying to look for exercises I could do to help my disc, he popped up on my feed and said, "Do you have a herniated disc? I can fix you." And the more research I did, I was just so thrilled, because nobody has his impeccable record. No one. That's why I went to him. He knows what he's doing. He is crazy confident. His staff is amazing. They're so kind. They're so attentive. The lady that did my IV was so gentle. She did it and I was like, you're done already? The people here are amazing. This doctor knows what he's doing. God has his hands in his hands.
Amen. We are so thrilled that you were able to get your neck fixed here and avoid that metal plate and the fusion and the discectomy, which is totally unnecessary, by the way. I'm trying to help people understand the truth. There's no need for ACDF fusions anymore for degenerative disc conditions. We can fix it with the Deuk laser disc repair and the Deuk plasma rhizotomy. You can see in your video here, we went into your disc, we used the laser. We actually pulled out several big chunks of herniation. I don't know if you watched your surgery, but you could see them coming out from the back of the disc. I cleaned the back of your disc beautifully, got the foramen opened up. There was nothing in there when I was done. Now your disc is going to heal naturally without any problems. Is there anything you want to tell the rest of the world out there that you haven't already said?
If you're in any kind of back pain, any kind of neck pain, he's the only option because he knows what he's doing. Really, he can help you. He's helped people get out of wheelchairs. He's helped people be able to ride horses again. I mean, I'm gonna be able to go back on a jet ski. I'm gonna be able to go back to my life. Obviously not right now after my healing time, but I wasn't gonna be able to have that happen before. And I'm an adventurous person. So if you're an adventurous person, if you're in pain, if you want your life back, you need to come here. You need to come here. You will never regret it. You will never look back. I promise you with all of my heart. He's the one you need to be with.
Well, congratulations on taking the faith and getting it fixed.
Thank you. Thank you so much.
You're welcome.
You've made me so happy.
You have a beautiful family. Please tell your husband I said hi. He's a very smart man.
Absolutely.
And I'm very happy you're doing well.
Thank you so much.
You're welcome. All right, take care.
You too.
Let's get you out of here.